So today I'll be talking to you on chronic myeloid leukemia. It's the commonest cancer amongst Indian population, and majority of our physicians, general practitioners would see this malignancy now and then. They may present with a pain abdomen because of massive splenomegaly. They may present with a weakness because of anemia. They may present to an orthopedician because of bony pains. Henceforth, it has multiple manifestations, but the primary manifestation which caught an eye of any physician or any practicing doctor is raised blood counts. So henceforth, chronic myeloid leukemia is a clonal stem cell disorder, commonest amongst 15%. Survival was about 3 to 5 years before onset of new drugs. Incidence is 1 in 1 lakh, and presentation is usually in elderly, though no age is a bar. And I have seen patients as young as 10 years and as old as about 80 years old, but majority of patients will be in the age group of 60 to 70 years. So coming to clinical features, majority will be asymptomatic. For certainly you have, and once counts are there, they are relaxed. So this catches an eye that possibly there is some problem, but in majority of cases symptoms are gradual in onset: easy fatigability, malaise, anorexia, abdominal discomfort, weight loss, excessive sweating, and sometimes it presents an acute pain. Because of massive pain, you can get infarctions, or you can get shoulder pain, or sometimes urticaria. Coming to the physical signs, the commonest sign is anemia in form of pallor. Per abdomen examination reveals a splenomegaly, and because of severe anemia, sometimes you get functional murmurs in form of this and because of the bone marrow enlargement, since hemoptysis is going on in almost all the bones, you can get sternal bone. So you can see a picture of a patient who is having this chronic myeloid leukemia. This is a marking of massive spleen, which is almost taking stably for about 6 years. Then it went, and there is a minor accelerated. It takes the shape of a blastic crisis. That is, it presents like just acute leukemia. It can be in majority cases AML, and in some cases it can be ALL. Coming to the pathology of CML, how it starts. So once I was telling you that coming to the lab features, you orders chronic, you get a lot of nucleotide. TLC is above 1 lakh with all the stages of development, and this is known as leftward shift. You get hypersegmented neutrophils, you get basophilia, you get eosinophilia, a lot of metamyelocytes, myelocytes. Platelet counts can be normal or increased. So this is how it looks. You can see a basophil. It's unlikely to see a basophil, a mature basophil in peripheral smear, but in CML you can see. Similarly, you can see metamyelocytes, myelocytes, band cells, hypersegmented neutrophils in a peripheral smear, which is unlikely to be seen in a normal person. Coming to the bone marrow will be hypercellular, blast will be less than 10%. There will be increased metamyelocytes, myelocytes, basophilia will be there, eosinophils will be on a higher side, increased megakaryocytes will be there. This myeloid erythroid ratio will be increased, and with the passage of time, you can see there is a reticulum fibrosis which is setting in, and finally any myeloproliferative disorder like CML will land into a myelofibrosis, and it carries a worse prognosis. So this is a picture of bone marrow aspiration. You can see it's a almost starry sky appearance, all blue. So coming to the accelerated phase, there are 2 criteria, and we follow WHO criteria. As per that, blast will be about less than 19%. Basophils can be more than 20%. Persistent thrombocytopenia unrelated treatment. Platelet count can be more than 10 lakhs, which are unresponsive. Count. And there is evidence of clonal evolution. I'll tell you later on what is clonal evolution. And as I've told you that in a span of years to blast crisis in first 2 years, and then onwards, the rate of progression is about 10 to 20 to 25%. So you can say that in a 5 years, almost all the patients land in blast crisis unless they are treated. Coming to the criteria for blast phase or crisis, if we follow WHO criteria, blast more than 20% either in peripheral smear or bone marrow, evidence of extramedullary blast proliferation, and there are large clusters of blasts in the bone marrow biopsy. Coming to the international bone marrow transplant registry criteria, it is more than 30%, and there is evidence of extramedullary blast crisis. Coming to the genetics of CML, how it starts. So this is a classical disease in which you can understand that how cytogenetics play a vital role in genesis of leukemias. So this is our normal karyotype, but in this patient or in this case, you can see that there is a classical, so that is extra arm of 22 chromosome gets attached to 9, and similarly the 22 is decreased. So if you see translocations, that there is a cluttering. 9 goes to 22, 22 goes to 9. So if 9 goes to 22, it is known as 922. And if 22 goes to 9, it is known as 2029. So the classical Philadelphia chromosome is basically 22q minus, because this generates a fusion protein which is known as BCR-ABL, which has a tyrosine kinase activity, which drives cells for multiple proliferations. So this is how it looks at fish. You can see on your screens that 9 is red and 22 is yellow. And once there is a fusion, you can see in between there is a fusion genes. Clonal evolution, I was telling you, it is cytogenetic abnormalities besides a single Philadelphia chromosome, which will be required in patients with CML as their disease progresses. Almost 80% of patients with blastic crisis have additional cytogenetic abnormalities in form of YA plus or 11q plus